My name is Gary Greenswag. I'm the physician executive for the Physician Enterprise and work with Dr. Sagar, Ankita Sagar, who's our vice president for clinical standards, and Rachel, who you've met, and our Pediatric Ambulatory Collaborative, which has focused in a lot of areas, one of which is our overall strategy for that group is to create healthy adults, and part of that is behavioral health. And so we have started a series of what we call brown bag lunch and learns. So people bring their lunch, and we struggle because we are across from the East Coast to the West Coast, several time zones, to find out when lunch is. And our faculty has been kind enough to do 2 or 3 sessions in the course of a day in order to have people be able to attend. So this has been done in collaboration with the Creighton School of Medicine, and we are extremely happy to have Dr. Monica Arora here today to talk about anxiety in children and adults. And I think the goal of these visits is to increase I'm a primary care physician, a family physician for many years, had children of all ages in our practice. And I think it's about increasing our level of comfort in taking care of children with behavioral health concerns. And that may not be all behavioral health concerns, but certainly there are ones that should be in our scope of practice that we could help manage. So Dr. Arora is an associate professor of psychiatry and is board certified in both adult and child adolescent psychiatry. She's the vice president of the medical staff at Emmanuel Medical Center in Omaha, Nebraska, and chairman of the Physician Executive Committee and Quality Council for the Emmanuel Hospital Regional Organization of Child and Adolescent Psychiatry and APA and AACP. She operates the inpatient psychiatry service for children and adolescents, and she has been there and doing that for the last 19 years. It is interesting that she, after attending medical school in Mumbai at Grant Medical College, she moved to Omaha in 1992, where she has remained until this very day. She did her residency at Creighton University. She did her fellowship at Creighton University, and she has been as faculty in that program since that time. She loves mentoring trainees at all levels: medical students, residents, fellows, nurse practitioner students, pharmacy residents, and PAs, all helping them grow professionally. We've met with Dr. Arora in advance. I think you'll find her delightful and quite knowledgeable, and we really look forward to her comments. So thanks for joining us. And Dr. Arora, I'm going to turn this over to you. Thank you very much for being here.
Thank you so much. The topic today that I'm going to be talking about is anxiety in children and adolescents. It seemed like we have a relatively short group. Please feel free to stop me anytime. We can have a discussion. We can have a more of a discussion format if you would like, rather than me giving a lecture. I'll start with the format. Please feel free. We don't have to wait till the end. If you have any questions or anything, I'll be more than happy to. You know, I'm an educator by profession, so this is something that's I'm passionate about. So if there's anything I can help you with, it would be a pleasure. So I have no disclosures. Hopefully by the end of the lecture, we should be able to have some idea about different anxiety disorders, how to identify them, screen them, and then evidence-based treatment of the anxiety disorders. So hopefully we'll have some idea about it by the time we are done. Just want to categorize the anxiety disorders in this slide. A lot of change between DSM-3, DSM-4, DSM-5. We are in DSM-5 TR, so revision. So DSM-5, this is what we have right now for anxiety disorder. We have generalized anxiety disorder, specific phobia, separation anxiety, social anxiety, selective mutism, panic disorder, and agoraphobia. I just want to remind you that OCD is not a part of anxiety disorder. Since we specifically did anxiety disorder, OCD is categorized into obsessive compulsive related disorders. So that's a different topic that I would not be able to address this session, but we'll be more than happy to discuss if you would want to rather know about that. I should be able to answer some of that questions too. And then PTSD that used to be also under anxiety disorder is now under trauma and stress related disorder. So there is a categorization of the disorders that has happened in DSM-5. I just want to make sure and mind you, the anxiety disorder I'll be addressing will be these. We have general anxiety, specific phobia, and going forward. So anxiety disorder, it is the basic description of anxiety disorder is avoidance, is the core feature, is like people get anxious. And one of the things they want to do is not face that, because that is how they actually try to relieve their anxiety or distress. So also fearfulness, distress, or shyness is also one of the core features of it. The expectation of a threat, they worry about it, they ruminate about it, they're anxious in anticipation, they have all the negative thoughts, they can't sleep, they're very hypervigilant, they are react out of proportion to what the situation is, catastrophic reactions, a lot of physical complaints, midline symptoms in the physical complaints. And one of the common things in child is parental accommodation. When our kid is sick, we want to go above and beyond to help them. If the kid is having a fever, I don't care if my child eats on the couch because they're just having a fever. I want them to feel better. Anxiety is more of a chronic nature. So a lot of time what happens, parents make a lot of accommodations, which in a way can be helpful, but can also be enabling in a lot of ways. So you'll see a lot of parental accommodations, parents changing their jobs or changing their times just to make sure the kids' anxiety is accommodated. Again, the anxiety disorders we'll be talking about is generalized anxiety disorder. We worry about multiple situation or activities, and these are worry wart. They have actually everything on their shoulders, all worry on the shoulder. They worry about the whole world, and those are more of a generalized anxiety disorder. Specific phobia is more like specific object or a situation. It could be height or blood product or an animal or flying. Those will be more specific phobia. And then what they do is they avoid going to those situations. Separation anxiety disorder are distress related with people separating from their caregivers. It used to be more of a childhood disorder, but they have integrated that a lot of adults also have separation anxiety disorder. Again, what do? They avoid separating from them. Again, the core feature. Then we have social anxiety disorder, which is worry about negatively evaluated by others. So what do? They avoid being around a situation in which people will judge them. So like going out, giving performances or ordering food or going to a restaurant or concert, they will actually have a hard time being there because they would rather avoid it to handle with their anxiety. Selective mutism also initially used to be a childhood disorder diagnosis, but again, it is also now integrated in adult. This is inability to speak in certain social situations. So there's nothing wrong with their ability to speak. Their speech is not an issue. They can actually have a conversation really well in a home setting or with a certain person. But when you change that situation, they will be selective mutism is like they won't talk in school at all, or they will not talk when they go to the mall or restaurant at all. So there are inability to speak in certain situation only, despite an established capacity to speak. And then again, you can see selective mutism would be more common in individuals with social anxiety disorder. Panic disorder, they are the people who have recurrent panic attacks. And the panic attacks, they're less, usually in adults, panic disorder is like, it is really, there's no specific trigger to it, but in kids, you can actually see more associated triggers that can lead to panic attacks. So this is a recurrent panic attack, and worrying about getting another panic attack, avoiding this being a situation where the panic attack happens and they cannot rescue themselves. Agoraphobia is effort to avoid situation which cause anxiety. So using a public transportation or open spaces, enclosed spaces, standing in line, being in crowded, being outside the home alone. So any of the situation they would like to avoid to be in. Those are individuals who can it can impair their ability to function. And then we have medical condition that cause panic attack. And if you have some of the individuals who have high hyperthyroidism or have underlying seizure disorder or pheochromocytoma or anything like that, they can actually present similar. And of course, a lot of the medication like antihistaminics and anti-asthmatics and sympathomimetics and steroids can also cause similar. Don't forget the illegal drug use, very common in adolescent population. Energy drinks, very common. So that's something that is a common question for us to ask. It is very common. It is one of the earliest disorder to appear. It's underdiagnosed, undertreated. It can be, prevalence is variable. It can range from 20 to 30% overall anxiety disorder. But if you can see that there is the percentage of the anxiety disorder is different, with the specific phobia being the most common of those disorders at 20%. So you would see, like all the anxiety disorder we talked about, there is a mean age of onset is about 11 years. But again, according to which disorder we have, you will see presentation in that in a certain age group. So like separation anxiety disorder is more common in preschool, early school age. But again, it doesn't mean that it cannot happen later on, but this would be a more prevalent population that you're going to be looking at. Specific phobia is more common in school age, social anxiety disorder, later adolescent and early late school age and early adolescent, and then your generalized anxiety disorder, panic disorder, and agoraphobia more at the later adolescent and younger adults. So again, all these disorders can happen anytime during their age, but if you actually had to categorize certain disorder more common in a certain age group, that's how you would look at. It can be acute onset, but the course can be chronic and waxes and wanes. There was a study done by Rappi in 2009, which said the anxiety disorder per se have no association with the family size, parental marital status, educational attainment, or the intelligence, which is really some of the things are important to really know. If the kid lives in a house with 10 people, is the anxiety prevalence higher in those situations than not? There was no association. More likely to have kids have more likely to have more medical problems, asthma, GI disorder, allergies. They use long-term psychiatry medical services, cause functional impairment, and actually can predict anxiety disorder in childhood, can predict other disorders in adolescence. So a childhood generalized anxiety disorder, those would actually, if not addressed in the right way, have a tendency to get into an adolescent conduct disorder. But you would think a person who would be anxious all the time will end up doing things that would be more of a conduct natures. They don't come alone. All anxiety disorder, if you have one anxiety disorder, there's a possibility you can also have another anxiety disorder, or you can have anxiety disorder. There's a higher percentage you'll have a depression associated with it. 1/3 of the kids with ADHD have anxiety disorder. We have learning disabilities, behavior disorders, substance abuse, eating disorders. So there's a lot of comorbidity. So you just have to remember that sometimes when you're doing anxiety disorder, you just don't screen for anxiety disorder. You may want to screen for other disorders also because they're highly prevalent in population like that. Because when you have a comorbidity, that's actually difficult to diagnose because of overlapping symptoms, but also causes more functional impairment. And it will also affect your treatment response, because if you are treating only one disorder, not the other, then the response is not going to be what you would like. So just a basic knowledge on that. And then now we have to figure it out. How can we help? So early identification, try to screen most of the kids. Again, you can screen younger kids if they're presenting with the symptoms. Successful treatment of primary caregivers' mental health. Again, anxiety also runs within the family. So a lot of the parents who have underlying mental health issues may actually enable some of that, or if they are untreated, then they cannot be a good support for the kids. So just want to make sure that they are able to, you're addressing the primary caregiver's mental health also. Treat the comorbid disorder and education about lifestyle modification. Effective management of stress, sleep, exercise, social activities, social media. I cannot emphasize more on social media. I do this day and night. I work with kids in a mental health inpatient unit day and night, and I will tell you about 80% of the kids have issues through social media. A lot of anxiety. I can see as adult how we can get affected by social media. So we are actually talking to the kids who are really not sure about themselves and finding their place in the world, how they get affected by all that stimulation from the external world. So I just wanted to make sure that some of that anxiety could be provoked by what they're being exposed to. So really clear boundaries about social media. We have younger and younger kids having access to phone with unlimited plans. And I really highly encourage to actually educate all the parents about, especially primary care, when you're coming for wellness checks and things like that, to actually help them educate about maybe boundaries about electronics and social media, because I think we are underestimating the power of social media on kids' anxiety. So the kids are coming to your office. You want to screen for them because you have enough symptoms to do it. These are all the scales that I thought they have data available. You don't have to use all of them. I did highlight the three that I really feel have been helpful. If you really want to specifically screen for anxiety, the screen for a child anxiety related disorder, the SCARED tool actually does really well. It kind of categorizes a lot of things. And then if you want to do any further, for example, a kid rated higher on your SCARED score, then you can actually pick one from the more specific and detailed assessment, and you can do one more of those just to be sure that you have gotten your diagnosis correct. But SCARED actually does very well. This is what a SCARED looks like. This is a child version. There is a parent version also. As you can see, there is a very simple phrases as to how they describe anxiety in different presentations of anxiety, and you rate 0, 1, and 2, and then you have score. At the end of the sheet, there is a scoring card that you can actually score kids in certain categories, and then you actually can further decide if you want to do another screen or not, or you can go ahead and treat them. Again, child and parent version, but those are screening tools. We have some diagnostic tools, and the structured interview is just more reliable for diagnosis than any other scale. But the KIDDIE-SATS or anxiety disorder interview schedule or DISC, these structured interviews are available. The only concern about these interviews are very time consuming, and these are more available initially for research tools, so very detailed. You can't go wrong with those, but it's just like, I think it's very time consuming. For most of the times, I think if you do a good diagnostic assessment and do the scale, you should be able to at least gauge the anxiety disorder enough to treat. But if you wanted to actually know, there are structured interviews available, which helps you with that. So once you have, screened it, and then now you see that this kid is high on the anxiety scales and the symptoms say, like, maybe I need to do something further. So what you would do, we would do an interview. We discuss the confidentiality and then also interview the parents for an initial complete assessment. Information should be obtained both from kids and their parents. You can interview kids. It's totally up to your professional judgment how you want to do it. I always recommend taking an opportunity to interview the patient and the parents separately, at least for a little bit, because the kids actually respond to answers differently when they're interviewed with the kids, and sometimes anxious parents exaggerate symptoms too. So you can decide who you want to interview first. Make sure you get all the information about the past psychiatry, medical. I highly encourage family history, list of all the medications prescribed and non-prescribed. There is a lot of herbal medication consumption in the community right now. So just highly recommend checking on those too. Talk about, what is going on in school, family, social, what is the family structure? Is there a divorce going on? Any change in the financial status, anything change in the siblings, or any, change in the family dynamic? Those are important. Change in school settings, change in expectations at school. Those are things that are important to know. And parenting styles. And also very important to know is when in the course of interview, you need to really know is motivation behind these behaviors. So we do have kids who actually say they have anxiety disorder, cannot go, they get very anxious, but they work in a fast food center, a fast food place, which I believe can be very stressful, 40 hours a week, but they're not going to school. They've not been to school for 3 weeks, but they have not missed a day. Or they have no problem going out for sleepovers with friends, and they have no problem going out for concerts or going out of town trips. So it could be just related to school. So you have to really sometimes have a better judgment of like, really, what is the kid avoiding to do, and is there a motivation behind it? Midline physical symptoms, if you wanted to really start asking some of the questions, these are kids who have midline physical symptoms, very common. Stomach aches are very common. Headaches are very common. I cannot breathe. My chest hurts is very common. Are they sleeping okay, eating okay? Are these the kids who are needing repeated reassurances for everything, performance in school? How are they doing it? How do they do avoidance of outside and interpersonal activities, and if there were any recent triggers? So those are some of the other things to ask. So you have realized that this kid has anxiety, whichever category you want to bring in. And there is no standard lab test you can do. There is no, I wish we did. I would have loved that, but there's no standardized lab test. But also, it's totally up to your medical judgment if you feel that there is a medical issue that, genetically or patient has other symptoms that indicate maybe a medical problem. Thyroid seems to be something that we have noticed significant. They look like having a panic attack, but they could have had like a hypothyroidism. Then also consider family history of mental health issue and medical illnesses. Again, differential diagnosis is important. There are a lot of overlapping presentations in ADHD, depression. You can see how autism spectrum disorder, a higher functioning, can look like a person with selective mutism or social anxiety disorder. They can look like that if you don't really get a good history. So learning disorders are common, bipolar disorder, psychotic disorders. Some of their symptoms can have overlapping symptoms, a lot of medical conditions and some medications. So this is just a slide to help you understand that, hey, just because it looks like an anxiety, there could be other disorders too that may actually present that way. So in order to rule it out, you have to be very sure about the presentation that this is anxiety and not something else. So once you are sure that this is anxiety disorder, it's a multi-pronged collaborative treatment plan. Informed consent is, what the diagnosis is, what is the purpose of the proposed treatment, what is the risk benefit of doing a treatment, not doing a treatment, and what are the alternatives if you don't treat that. If you're going to implement a high quality treatment plan, it has to be safe, effective, efficient, feasible, equitable, timely. Prioritize according to the acuity. You may want to actually make sure that if you're watching somebody that, okay, I know, I'm going to put it in my notes that this kid is a little high on anxiety, but nothing enough to treat. There is a family issue going on. Maybe I'm going to monitor this kid, and the kid doesn't come back for a year for another physical. And then, we have missed an opportunity to intervene. So if there is a kid who ranks a little high, it may not be a bad idea to check on them a little bit later and not wait. If they're healthy, they may not come back to you for another year, and maybe we could have intervened earlier. And again, it has to be child and family centered according to the cognitive, linguistic, and cultural levels. We have a lot of people from different cultural backgrounds now, and the different understanding of what anxiety disorder is and the hesitation in treatment. So we just have to make sure that it is family centered, because it's only going to work if we have the patient and the parent both bought on the treatment. But again, how also level of care determination is guided. If the patient is suicidal, it has to be more of a partial hospital referral or an inpatient referral, but otherwise you can actually handle it more on an outpatient basis. So it starts from psychoeducation all the way to safety plan. There is a lot of resources available. I just want to make sure this is our ACAP actually has anxiety in children. It's facts for family. A lot of time, very simple descriptions of what these certain disorders are. If you actually log in, it's free, and you can print it out for the families. It's for to have them understand what anxiety disorders are. And there are also a lot of resources available in the resource center. And these are something you can access through American Academy of Child and Adolescent Psychiatry website. So before we start into all the treatment, let me just give you a synopsis. So then we can open it up. So we know is therapy works, and we know medications work. We know that therapy and medication by themselves work, but if you combine them, they work better. So you'll never go wrong, whether you start therapy or medication first, the kid will respond. And it's a matter of, that the better response is if you actually sometimes combine things together, and more severe the symptoms are. It is, again, CBT is effective when it's done by experienced professional. There is a difference between CBT approach in a therapist versus a CBT therapist. So if we are talking about the data shows these are CBT therapists. These are people who are credentialed to do cognitive behavioral therapy. A lot of the therapists are of good understanding of what cognitive behavioral approach means, but they're not doing CBT treatment per se. Medications, if you're going to choose a medication, SSRIs are your drug of choice. You can consider atypical antidepressants as a second line if you want to. We recommend SSRI as a first choice. There is very limited data on augmentation strategies. There's limited data on benzodiazepine, and we'll go over all of this again. But then several medications we use in the kids, and be ready that you're going to be doing an off-label prescription on this one. Best outcomes if you focus not only on the acute, but also the continuation and the maintenance phase. Treatment strategies based on age, severity, impairment, and comorbidity. Mild severity, you can just go with CBT and the patients can show positive response. You can add a medication to a CBT just if the symptoms are not getting better or there is an acute symptom reduction needed. You can do a medication in addition to it, but therapy per se, first line will work. Moderate severity, again, we recommend CBT. You can add a medication to it, and pretty similar approach. And you just want to maybe have more of a multimodal approach of making sure the school is involved, the parents are involved, and having more intense approach that way. When the severe, we actually do recommend CBT and medication may be necessary. So mild, moderate, you can pretty much actually just do CBT with or without the medication, and they will respond appropriately. You just have to do more intense things. Severe, we actually do recommend combining CBT and medications of severe. In addition, CBT is cognitive behavioral therapy, and interplay between the thoughts and emotions and behaviors and how that affects your thoughts and how all of these things affect each other. That's a standard CBT. What is also in a therapeutic approach, we have psychotherapy approach, we have social skills trainings on all these kids who are really struggling with social anxiety or like selective mutism. Social skill training is very helpful. Assertiveness training is helpful. Self-esteem skills are helpful. And not to undermine the working with the parents in school it's going to be something that's going to be a major factor that you'll have to work on in treatment, because that's where the big impairment comes in school. So how do you consider medication? You first have to decide, what are you treating? I think that's the key thing, is like if they're trying to avoid something, or there is some symptoms are treatable by medication, some things are not. So when you are giving a medication to a patient, you have to really see, what am I trying to get a relief from? Because you cannot change situations. What has worked, what has not worked? Is the drug really going to help this? This kid is being bullied in school. That's the reason he's not going. I'm not going to go give a med to kid and say this should help you. That's not going to happen. So those are some of the factors you have to really keep it in mind. And if I'm going to give a medicine, what are the risk associated with this medication? So how would I know if this medicine is helping, or when would I know how to stop? So these are all the medication questions that comes to my mind when I have to start a medicine. And that too, I do an inpatient. It's like, I would say 60-70% of the kids who come to my inpatient do not leave on meds, because even though they were trying to kill themselves, or they were having thoughts of wanting to kill themselves, because if I know there are social factors that I can't fix with medication, I will not start them on meds. I would definitely recommend therapy first. Again, antidepressant dose and response depends on so many factors. So those are some things that we have to really keep it in mind when we're actually taking care of the kids and discussing medications. We talked about off-label use. So if you can see, this is a table that I think it's a good summary of it. It's all the medication that we have, like we're using for depression, anxiety on your left. Then we have pediatrics, and then we have adult, and then a half-life. As you can see, if you go with SSRIs in the pediatric section, you can see FDA indication. There's not a single medication which is FDA approved for use of in kids for anxiety disorder. We have major depressive disorder, so we have two of the medications, Prozac and escitalopram and fluoxetine, who are FDA approved for major depressive disorder. None of the SSRIs are actually FDA approved for anxiety disorder. The only medicine which is FDA approved for anxiety disorder in child and adolescent population is duloxetine. And other than that, none of them. So when I'm talking about you have to use it off label, that would be pretty much entirety of your SSRIs are off label. So I wanted to make sure that you're aware that there are some. If you go over to the adult side, you can see there is a lot of indications for generalized anxiety disorder, panic disorder, social anxiety disorder in adults. We do not have those indications in the kids, though. We use it because we know it works, and we extrapolated some data from the adults. So for clinical purposes, we actually feel that there is a value to using these medications. Would you do a gene site testing for the kids before you start on medications? My answer is there is no clear evidence for a role at this time. Sometimes I think it hurts more than it helpful. We're talking about very anxious kids. We're talking about very anxious parents. So gene site testing, if you guys have actually worked with it before, depends upon what gene site testing you do. There is a green column, orange column, and a red column. And what happens is sometimes when they do gene site testing, most of the medication that I would ever prescribe in the kids end up on the red column, means like I can't use them, and they'll put something on the green column, which I would never use on a kid. But then it's really hard to sell to a parent that, oh, you know what, but I've done the gene site testing, but I won't prescribe them anything that on the green, but I'm still going to do red. So then you're talking about anxieties. That is not going to help the anxiety to start with if you're going to start treatment like that. So I just want to make sure there has been no additional benefit. I would just recommend for pharmacogenomics testing to be done only if you really are utilizing medications in which the patients are really having a hard time with tolerability, with changing the dosage and stuff like that, and they're either having a paradoxical response. I may do a gene site testing, but that's not traditionally what I'm actually recommending any of our parents to do. We have created more issues with that gene site testing that help the kids at times. So if you choose a medication, we talked about these medicines work. There's just a little bit of data I want to share. This is an NIMH-funded study in which they did social anxiety, specific phobia, and generalized anxiety disorder, about 500 kids. It was a 12-week study in which they compared, let's combine medication versus, let's combine medications and therapy, medications alone, therapy alone, and placebo. As you can see, a combination treatment was 81% response, and CBT and sertraline, which is Zoloft, the medicine used, has a comparable response. So obviously it was very, back in 2008 when they did this, that there was definitely a positive response to this medication. And of course, this is another graph. If you can see, the orange bar is the reduction in the remission of the symptoms, and you can see there was significant remission of the when you do the combination treatment. Also, out of that study, we found out that younger kids with anxiety do better with all treatments. Again, there is medication is well tolerated, but they also have more side effects. So it's really, you have to adjust the dose accordingly. Again, you also don't want to undertreat the kids, because if you're worried about side effects, you may undertreat them and not get the optimal dose that you should have. There was no increase in suicidality or self-harm during that study, and youth with ADHD were included, but somebody who had PDD or depression, those were excluded from it, because then it would have been hard to tease out anxiety or depression, what got better. So kids with MDD as a diagnosis were excluded from the study. They followed these kids for 4 years after the CAME study was completed, just to see long-term tolerability of this. So when they followed them for 4 years and they were assessed annually, they found out 22% of them had a stable remission, 30% continued to be chronically ill, And then 48% relapsed. Anxiety disorder free at least one visit, but then met either the same diagnosis or a different diagnosis during a different visit. So all the data says that male gender, if increased likelihood of remission, if you wanted to literally look at the candidate who were going to have a higher percentage of remission, male gender, absence of baseline social phobia, baseline family functioning was better, didn't have frequent negative family events, life events, and younger age of starting. So if you have all these factors going, you had a higher possibility of having a remission. All right, we now if you could decide about using an antidepressant, just make sure start slow, increase slowly, see them frequently, assess them regularly. So it says response should be assessed at 4 to 6 weeks, but once you start the medication, we definitely recommend a weekly contact till you have reached a therapeutic dose, and that's when you start seeing the response. You can actually follow up every 4 to 6 weeks. By 12 weeks, if the goal should be remission of symptoms, and if they're not remitted, you may want to actually look at it. Should you be doing something else, or should we add a different intervention in addition to what you're doing with the medication? SSRI by class, these are class side effects. This is not a specific side effect. These are all class side effects. GI symptoms are pretty common if you start an SSRI. Zoloft or sertraline seems to be a little more harsh on your stomach as compared to some of the others. Sexual dysfunction, again, a huge non-compliance rate with your adolescent males. Paroxetine seems to be notorious with that. So I just want to make sure that some of your adolescent teens will stop taking medications and not tell you, because sexual dysfunction is not what a common thing we would assess in a teenager, if they come. So I just want to make sure that that's a huge non-compliance issue. Again, you can use it with seizures, but with precaution. And then again, there are some reports of some bleeding events. So you have to be careful when you use aspirin. Again, not very common, but it happens. If you give SSRI, do they switch to mania and hypomania? Well, only if there is an underlying high risk factors to it. So it's not that if there is no high risk factors to it, and if you give somebody an SSRI, they'll be manic. There is definitely a triggering factor to it. It is sometimes very difficult to differentiate from behavior activation. It appears later in the treatment as compared to the activation, though. So sometimes when you stop the medication, the symptoms go away. Their manic symptoms or hypomanic symptoms go away, but sometimes you have to give more medication for the mood stabilization to do it. But again, that's something can happen if there is a high risk factors associated with it. Serotonin syndrome can arise within 24 to 48 hours. Again, it's a medical emergency. Mental status change, neuromuscular hyperactivity, autonomic hyperactivities. Again, it requires a hospital-based treatment. So be cautious when you're using some of these medications, also illicit drug use, and also some of your St. John's wort, which is serotonin reuptake also. Sometimes people are self-medicating themselves before they come to you, and they're already taking St. John's wort, and you give an SSRI, it's an additive effect. So just something to keep it in mind. So we talked about activation, early in treatment or right after dose change in 24, 48 hours. Again, this is increased activation, increased agitation, it's ants in the pants, restless. And it's, again, if that something happens, you have to stop it right away, decrease the dose and stop it. Doesn't go away. You can't. And so if you say, we'll give it more time, your body will get used to it, not with this symptom. Like if there's a behavioral activation, you're going to go ahead and discontinue it. You can switch to another SSRI if you would like to. Just because it happened with one SSRI does not really mean you cannot use another SSRI. Go ahead and use another SSRI. There are some non-activating antidepressants, which are, again, not your traditional SSRIs, but there are some of those available. If you wanted to try instead of an SSRI, you could do that. Black box warning. I do want to spend a little bit of time on that. This is a black box warning for anyone age 24 or younger, that when you take antidepressants, you have sometimes the suicidal thoughts get worse. There is, doing an inpatient, this is what I do. I would tell you very, very commonly, we will have kids come into a hospital and say, that you'll say like, why are you even here? Because I'm having suicidal thoughts. Well, but you're not depressed. There is no stressor. Actually, you're glad that you're getting help. Things are going better. But why are you, well, like, I'm not understanding, why are you suicidal? And one of the very common answers is because my doctor said that in 2 weeks I'll be suicidal. I said, that's not what your doctor said, but that's okay. But that's what they're understanding. If you remember, you're talking to depressed and anxious kids, and they are, they worry. And if you tell them this is the biggest warning placed on the medications, and you just lost them right there, because that's all they're going to focus on. So I just want to tell you that sometimes clinically, what helps is, we talked about mania, hypomania, activation. I start with that. I said, this is a medication. It is not a fixed bill. So once I give you this medications, I just want to make sure these are the common side effects. But remember, this is not a happy pill. So if I give you this medication and you're extremely happy on this medication, and people are saying what's gotten into you, that's not supposed to happen. This is not supposed to make you extremely happy. So if that happens, you have to let me know. But what happens is, if we give you this medication and your feelings and your thoughts gets worse, you're actually feeling worse on this medication, your thoughts are getting worse, you're getting more of these self-harm thoughts. That's not supposed to happen either. So then you let me know. I do like to bring both of those factors together, because medication-induced hypomania or mania is equally dangerous as black box warning of suicidality. But if I balance it out, then they're not just focusing on one thing. So sometimes I just want to make sure, on an average 8 to 9 admissions a year is purely just because the doctor did a good job of educating them about black box warning. So again, number 3 to harm is about 143 for one. So it just really, that's not very typical presentation for suicidal ideations in our hospital, is because that's not the reason they're coming to our hospital. But I will tell you that it is just one of those things, you're just like scratching your head, like, what did I miss? Why is this kid here? Because they were educated well. Again, if you did an SSRI, you did all the right things, you started the medications and it's not helping. So you can rule out a general medical condition. Maybe there is something going on, or reevaluate. Do you have the right diagnosis? Have you ruled out any comorbidities? Is there any other factor going on in the family, in the school? Are they using drugs? Are they even taking my medications? Or like, okay, let me call the pharmacy and see when the last time they had actually refilled the medications. So these are the augmentation or adjunctive strategies. I will go over these are just a list of it. I'm going to go on with that. So if you had somebody on a medication and an SSRI, and then it kind of pooped out, and like, it's just like you've done the maximum due diligence, compliance is fine, then you decide, this is not working, I'm going to cross taper to another medication. You can do an SSRI or an SNRI. That doesn't matter. That's totally up to your judgment. There is nothing wrong with going either way. But what happens is you took them down. For example, we'll just take an example of fluoxetine. You took the fluoxetine down and you were going to do escitalopram, and you did that. And all of a sudden in mid, you didn't take it off completely, and your 10 of fluoxetine and 10 of escitalopram, and the kid is doing the best that he can. Don't worry about it. Don't stop it. Just let them be on 2 SSRIs a little bit longer. Then you can stop your tapering process over there, and then give them some more time, and then try to take it. So just because they're on 2 SSRI doesn't really mean they can't be on it. We prefer monotherapy as much as possible, but if you had the right recipe, then that's totally okay. Same thing with an SSRI. If you were in a process of cross tapering from an SSRI to SNRI, and you just found a perfect combination, stick with it. There is no harm on having 2 medications, but the goal would be ultimately to have 1, but you may want to take a little bit longer at that time. Why not SNRI as a first line? You can. We just have more data on SSRI. Duloxetine is the only medication which is FDA approved for generalized anxiety disorder. As you can see, there is a better response when compared with placebo. The duloxetine is the same category as venlafaxine, which would be Effexor. And again, Effexor does not have FDA indication, but it is, they did have a study for pediatric generalized anxiety disorder, and it shows efficacy and safety of effects in treating generalized anxiety disorder in kids. So if you wanted to do, there is a data available of an SNRI. I'm going to skip that for a little bit. As you can see, there is a SSRI produced faster and greater improvement in anxiety symptoms as compared to SNRI. And then in the weak relation, and also about the low dose and a high dose SSRI. Usually kids with anxiety disorder end up using a little higher dose relatively. So if you're taking an SSRI, things were going okay, but like you need something more, it's not enough. So would you ever use tricyclic antidepressant? I wouldn't. I have different options of what I can do. Too many side effects, limited support available in clinical trials, and for tolerability. So I really, that's not something I would really want to. But again, is there a room for it? Yes, absolutely. Would it be my first or second choice? Maybe not. Benzodiazepine, limited efficacy in small controlled studies. You can use it. There is no harm in using it. I'm not against benzodiazepine because they're effective medications if used appropriately. As long as it's just a short-term use, I think there is a value to it. Definitely not recommend in the long term. So this would be more like if I've started an SSRI, but this kid is really having a panic attacks to the point they cannot even come out of the house. Maybe if a little bit of SSRI is already in the system, it takes a little time to build up in the system. You give a little bit of benzodiazepine to, bridge that gap. You could do that. And then, but again, this is highly abusable, dependence issues. That can be abused by the parents, and they can sell this medication. Tolerance can happen. So there's so many other factors that is a big no-no for us. Again, if you want them to be exposed in a therapy, but they are so worked up that they cannot even be a part of therapy. So really therapy won't do anything for them if they cannot participate. So sometimes I'll use a low dose benzodiazepine. Buspar is something that people have used quite a bit, especially for generalized anxiety disorder. There are no published controlled studies in child and adolescent population on the effectiveness. It's a 5-HT1A partial agonist. Biggest drawback about have I used it? Yes. Does it work? It's kind of hard to tell sometimes because I don't really think I can ever get compliance with that. This medicine for a good effectiveness needs about a 3 times a day dosing. And I can guarantee you with the teenagers, they can't get a 3 times a day dosing. So it's really hard to know the efficacy of this medication because of the compliance issues. Can it be used with an SSRI? Absolutely, it can be, but there is not a whole lot of study. Clinically, has it helped? Yes, but it's a hit and miss. Would I ever consider alpha-2 agonist, which would be more of a clonidine or guanfacine? Those are very common medications we use for ADHD for alpha-2 agonist. There is no controlled study for anxiety, but I really feel they do have a room to use because if they have a autonomic arousal because of the anxiety, and sometimes that does help if the autonomic arousal is high enough that it impairs their ability to function. A low dose of these medications can be helpful. But again, there's a rebound hypertension with abrupt discontinuation, and you have to monitor the blood pressure, EKG. We use that for ADHD all the time. So something that we are very comfortable using. So if you ever, for restlessness and autonomic arousal, if you wanted to use this, there is a room. You can actually try maybe the 0.5 of guanfacine twice daily. That would be helpful. You can use it. Beta blockers, performance anxiety. A lot of people have used beta blockers in the past, and there is, again, not a whole lot of data available child and adolescent population, issues with tolerability. So if you want to use a beta blocker for performance anxiety, I just want to make sure they have tried it enough that you don't want to give a beta blocker and they go up on the stage and fall down because they're not hypotensive because the body didn't tolerate it. So the people have used beta blockers and low dose of propranolol for performances. It works. It's just like you have to be very careful because of the tolerability issue. Have I ever used lithium for anxiety? Not necessarily for anxiety, but I have used lithium. There's chronic suicidality and a depression related to it. Lithium has a room for it, but hopefully that's not something that we would traditionally use in anxiety disorder. I did mention stimulants over here. We have used good for SSRI-induced apathy. We use a lot on geriatric population issue. I just want to make sure that we talked about how ADHD and anxiety, they are very close to each other and they are comorbid with each other. A stimulant can actually make the anxiety worse too. So if you're going to be treating ADHD and anxiety, there's a very fine balance. It's a Goldilocks, combination that you just have to have a perfect combination so that the stimulants are not worsening the anxiety. There is no role of antipsychotics in the treatment of anxiety disorder. It's probably more used for OCD or irrational and cognitive rigidity, but not so much in a traditional anxiety disorder. There is a lot of providers and outside in practice who are using low dose of Seroquel or quetiapine, 25 milligram or 12.5 milligram. There is really no room or use for using those medications because of the high risk benefit ratio. So I just wanted to make sure that that's something that I would traditionally not use. Antihistaminics. There is a room for Atarax, which is hydroxyzine and Benadryl. We have used that pretty common. Actually, hydroxyzine seems to be very popular in our practice, anywhere from 10 milligram to 25 milligram to 50 milligrams, once a day, twice a day, as needed. It's very flexible. I like Atarax better than Benadryl because I feel that some of your nasal passages are less dry with hydroxyzine as compared to Benadryl, and it's less sedating. So hydroxyzine is something that in lieu of, instead of like a benzodiazepine, I think hydroxyzine can actually have a very good role in using if you wanted to use it for a short time. And of course, it's non-sedating and you can use it as a PRN too. All right. So when to refer out, if there's an emergency, patient is psychotic, suicidal, refer out. If there are severe unremitting depressive symptoms and things are getting worse, refer out. If you have tried your best and you have utilized the right approaches and the patient is not responding and you wanted them to actually send it to a specialist, then that's when you would refer out. So at this point, most of things can be managed at family practice level, but if it ever goes beyond to the point that you feel uncomfortable, that's when you refer out. I think it comes down to your comfort level. And if you've done your due diligence to do the right thing, to do the right referral, and if the response is not the same, then I think it's appropriate to refer it out. I think that was my last slide.
Thank you so much, Dr. Arora. Again, that was so informative and always taking away some really important points throughout your talk. We are about, 9 or 8 minutes, maybe 7 minutes to the hour. We'd like to open it up to maybe ask Dr. Arora questions, share a particular case, less any patient identifiers, to maybe get some recommendations or guidance. So please feel free to unmute yourselves and ask away.
I've had a lot of patients who seem to think that the cure for anxiety is use of THC or marijuana, and then it seems as though it continues to get worse as they become more dependent on it. Do you have thoughts on self-medication with marijuana and its effect on anxiety symptoms for them?
Absolutely. And this is actually, unfortunately, this has been an ongoing battle with anxiety, with marijuana use. I think it's for all the kids, it's an answer to everything. If you have depression, marijuana. If you have anxiety, marijuana. ADHD, marijuana. So I really feel that there is really no data suggests that there is, of course, there's no studies done like that, but we do believe that there is a negative impact of marijuana on kids with anxiety disorder and depression. And what happens is, in addition to already having anxiety, the amount of issues and trouble they get into because of marijuana further exacerbates their anxiety. So there is really no data that would suggest that marijuana has any positive influence on anxiety or any disorder per se.
And have you been successful at convincing them of that?
You know what? Every day is I try every day, that every kid that is going to be, there's definitely a lot of data that suggests that, when they had when the kids come and they actually have used drugs, we get a lot of drug-induced psychosis. So we get a lot of kids who are acutely psychotic because of using marijuana, in which either it's laced or a different preparation of marijuana that's coming out on the market, and that is turning the kids completely psychotic. So when you talk about long-term prognosis of marijuana-induced psychosis, there is a 40% chance that these kids will end up having a psychotic disorder if they had a psychotic episode after using marijuana. So I do share a lot of that data that, it's not as naive as you think, because you would think cocaine or meth would cause more psychosis. Actually, marijuana has the highest incidence of turning into a long-term psychotic disorder instead of cocaine and marijuana and meth. So I try my best every day. We've actually had a lot of parents come in and ask us for cannabinoid oil and, prescribe their kids with it. And it's been an ongoing battle in regards to that. I, of course, personally and professionally would not recommend that.
I'm sorry, Anne, were you going to ask a question? I saw you come off mute. Or
Yeah.
Anna?
Yeah, in line with the same questioning, for our patients that are chronic marijuana users, how comfortable are you putting them on an SSRI?
I'm not, ideally in an ideal world, I would like for them to get off the drugs and I can reevaluate them in 2 weeks. And that's the ideal situation I would be in, but I don't live in an ideal world. So for me, I really feel as long as I know what the origin of the symptoms are, sometimes drug use is their sense of self-medication. There is really nothing that impairs my ability to use SSRI with marijuana. I would definitely do my education. I will get them a chemical dependency evaluation. If I have to get them in a treatment, I would, but I won't hesitate in using an SSRI just because they're using drugs, because I really feel if they're self-medicating the symptoms, if I don't substitute it with something, they'll continue to relapse.
Thank you.
You're welcome.
Just a few more minutes. Anyone else? Good discussion, good questions.
And actually, Anna, I just wanted, that's the same similar. If you ask me a question, would I hesitate using psychostimulant with, if somebody has ADHD, would I hesitate in using psychostimulant in a kid who's using marijuana? My answer would be no. I will, I would still treat it because they could be using marijuana as an impulse control that needs to be tailored down. And if I don't treat their ADHD, I may have to keep a very close eye on how I treat them. I may use a non-stimulant if I want to treat them, but I would still treat their ADHD, despite of them using it.
Thank you, Dr. Arora. We're about 2 minutes till. Is there any other good questions or recommendations or so forth while we've got Dr. Arora on the line? All right. The presentations will be available on the resource library. So we will make sure that you have access to that. And again, we thank you for spending your lunch hour with us. Have a lovely rest of your week.
Thank you so much.
Thank you.
Thanks.